Hello, dear friends. I hope this lecture finds you well and healthy. The subject of today's lecture is abdominal radiology. I would say that this is such a comprehensive subject, therefore I divided it into two parts. Today I will be talking about gastrointestinal tract radiology. Abdominal radiology. First part, gastrointestinal tract radiology. Goals are gastrointestinal tract anatomy, diagnostic imaging, and radiologic science, gastrointestinal tract diseases. As you know, the gastrointestinal tract consists of a hollow muscular tube starting from the oral cavity where food enters the mouth, continuing through the pharynx, esophagus, stomach, and intestines to the rectum and anus, where food is expelled. Imaging modalities in gastrointestinal tract are plain X-ray methods, contrast examinations, ultrasound, computer tomography and magnetic resonance tomography of abdomen, and methods of nuclear medicine. Plain X-ray. Common abdomen films are anterior-posterior supine X-ray. As you can see here, patient is in supine position. Anterior-posterior erect film, patient is in erect position. And a left lateral decubitus position. Many structures are not clearly defined on a radiograph of the abdomen and therefore can't be fully assessed. In this picture, you see X-ray film of abdomen. You see bones, soft tissues. You can see gases inside of gastrointestinal tract. All these densities we divide into 5 main parts. Gas appears as black areas. Fat appears as dark areas. Soft tissue and fluid appear as light points. Bone and other calcified structures, they appear as white points, and finally metal and foreign bodies, they appear as intense white points on plain X-ray. Indications for plain abdominal radiograph are suspected bowel obstruction, suspected perforation, suspected foreign body, and renal tract calculi. On plain X-ray, stomach is visible in the left upper quadrant of the abdomen. The lowest part of the stomach crosses the midline. The stomach may be visible if it contains gas or air. It's not visible if it's either completely empty or fluid filled. In this picture, you can see stomach. Small bowel is in central position in the abdomen. You can see on X-ray valvulae conniventes, mucus folds that cross in the full width of the bowel. But large bowel is peripheral position in the abdomen. You can see haustra. They contains feces. Okay, on plain X-ray you can see liver borders. The liver lies in the right upper quadrant and is seen as a bland area of gray on an abdominal X-ray. The superior edge of the liver forms the right hemidiaphragm. In this patient, the breast shadow, red line you can see, overlies the liver, and markings of the right lung are visible behind the liver. The gallbladder is only rarely visible on abdominal X-ray, and this patient has had cholecystectomy. The clips mark the previous location of the gallbladder. Natural contrast between the kidneys and the low-density retroperitoneal fat that surrounds them means they are often visible on X-ray of the abdomen, left kidney. They lie at the level of from thoracic 12 to lumbar third and lateral to the psoas muscles. The right kidney is usually slightly lower than the left due to position of the liver. The spleen lies in the left upper quadrant, immediately superior to the left kidney. The bladder has variable appearance depending on how full it is. It has the same density as other soft tissue structures due to its water content. Bones visible on an abdominal X-ray include the lower ribs, the lumbar spine, the sacrum, coccyx, pelvis, and proximal femora. Contrast investigation of the gastrointestinal tract is so useful in medicine. First of them is oral contrast investigation, and barium sulfate is the best contrast medium for the gastrointestinal tract. Atomic number of this contrast is high. It produces excellent opacification, good coating of the mucus, non-absorbable, non-toxic, and it's completely inert. This fluoroscopy, real-time X-ray, and after drinking barium sulfate you can see esophagus and stomach. Patient drinks barium sulfate and you can see lumen of lower organs such as esophagus, you can see gastroesophageal junction and stomach. Okay. Limitations are barium sulfate causes chemical peritonitis when extravasates into the peritoneal cavity, hence it's not used in suspected perforation of stomach and intestine. Extravasation into bronchial tree will cause inflammation and granuloma formation, and barium inspisation in case of colonic abstraction heart stones. Contraindications are tracheoesophageal fistula because the barium should not pass into the respiratory passage. Therefore, to diagnose these conditions, water-soluble non-ionic contrast media such as Omnipark or sometimes Ultravist are used. And one of main contraindications is perforation. And other available oral contrast for gastrointestinal tract is urographin, which is a water-soluble contrast medium which does not cause chemical peritonitis or colonic abstraction. The principal value of water-soluble contrast media is to demonstrate leaks from the bowel and outlining fistula tracts as they are safe in perforation cases. Okay. Next method is computer tomography of abdomen. As you know, computer tomography of the abdomen and pelvis is a diagnostic imaging method used to help detect diseases of the small bowel, colon, and other internal organs, and is often used to determine the cause of unexplained pain. CAT scanning is fast, painless, non-invasive, and accurate. CAT scans of the abdomen can provide more detailed information about abdominal organs and structures than standard X-rays of the abdomen, and thus providing more information related to injuries and or disease of the abdominal organs. Computer tomography may be done with or without contrast as simple X-ray method. Contrast refers to a substance taken by mouth or injected intravenously that causes the particular organ or tissue under study to be seen more clearly. In this picture you can see computer tomography of abdomen. Okay, this axial plane, this coronal planes, you can see all structures such as liver, you can see colon, small bowel, bladder also, stomach, and duodenum. Okay. Next method in gastrointestinal tract radiology is ultrasound. As you know, ultrasound imaging of the abdomen uses sound waves to produce pictures of the structures within the upper abdomen. It is used to help diagnose pain or distension and evaluate the kidneys, liver, gallbladder, bile ducts, pancreas, spleen, and abdominal aorta. Ultrasound is safe, non-invasive, and does not use ionizing radiation. Additionally, ultrasound may be used to provide guidance for biopsy. Ultrasound is used to help diagnose a variety of conditions such as abdominal pain or distension, abnormal liver function, enlarged abdominal organ, kidney stones, gallstones, and abdominal aortic aneurysm. In this picture, you can see ultrasound images of abdomen, of liver, gallbladder. You see the contour of diaphragm, liver parenchyma, normal gallbladder, gallstone you can see also. Okay. Next method is magnetic resonance tomography. MRI provides comprehensive information on gastrointestinal disease, including infections, inflammatory and malignant processes. But disadvantages of magnetic resonance tomography are bowel motion, contrast, calcifications, metallic implants, long procedure time, and claustrophobia. Okay. I'm sorry. In this picture, you can see a magnetic resonance tomography of abdomen. Next method is PET scan. In the PET scan, you know that a slightly radioactive form of sugar, which collects mainly in cancer cells, is used, and a special camera is then used to create a picture of areas of radioactivity in the body. PET scan can look for possible areas of cancer spread in all areas of the body at once, because this method is so important for diagnosis of tumors of abdomen, primary and secondary tumors. To summarize, we have already covered diagnostic imaging of gastrointestinal tract. As we use the principle of ABCDE in respiratory tract, it also helps us define pathology deeply in abdomen also. ABCD principle is A. Air in a wrong place, B. Bowel loops, C. Calcifications, D. Dense structures like soft tissue and bone densities, and E. Everything as foreign bodies. Let's begin from air. Okay. Looking for air in a wrong place. Pneumoperitoneum, air at peritoneal cavity. Pneumoretroperitoneum, air at the retroperitoneal space. And pneumatosis intestinalis, air along the bowel wall. Pneumobilia, and portal venous air. Okay. Pneumoperitoneum is abnormal presence of air or other gas in the peritoneal cavity, a potential space within the abdominal cavity, and the main causes are perforated duodenal ulcer, ruptured diverticulum, penetrating trauma, and other. Okay, the X-ray signs of pneumoperitoneum are: first, crescent sign, plain film showing appearance of a sliver of air, usually beneath the both hemidiaphragms in pneumoperitoneum. You can see it as semilunar translucency. And cupola sign, abdominal radiography showing free intraperitoneal air under the central diaphragmatic tendon, as you can see here, the cupola sign. Next sign is falciform ligament sign. Abdominal radiography showing the falciform ligament from surrounding air in pneumoperitoneum. You can see falciform ligament. Football sign, usually this sign we can see with massive pneumoperitoneum, most often in children with necrotizing enterocolitis. We can see it, football sign. In pediatrics and in adults, we can see football sign in pneumoperitoneum. Other sign is Rigler sign. Rigler sign is known as a double wall sign. This sign is seen on a radiography of the abdomen when the air is present on both sides of the intestine. When there is air on both the luminal and the peritoneal side of the bowel wall, we name it Rigler sign. Okay, pneumoretroperitoneum. The most common cause of pneumoretroperitoneum is perforation of the second, third, or fourth portion of the duodenum or retroperitoneal colon secondary to trauma, diverticulitis, or ulceration. Okay, important radiological signs is usually we can see it on the right side where the air can outline the right kidney and the undersurface of the liver. And in contrast to pneumoperitoneum, air in the retroperitoneum does not move freely with change in position. In this picture you can see it. The plain film demonstrates pneumoretroperitoneum with gas outlining the right psoas major. In this picture you can see also massive retroperitoneal air, free air into the retroperitoneal region. One of the signs we can see on abdomen normally is Chilaiditi sign. What is this sign? You know that in normally flexure hepatica is located below the liver, but in Chilaiditi sign flexura hepatica is located between liver and right hemidiaphragm, and on plain X-ray you can see it. We name it Chilaiditi sign. Okay, gas in the bowel wall, we name it pneumatosis intestinalis. Intramural gas can be seen in intestinal ischemia and eventually bowel infection. This is the most concerning etiology for intramural gas. Gas in the bowel wall in the neonatal period, whatever its shape, is diagnostic of necrotizing enterocolitis. You can see gas between the wall between the bowel wall. Okay, and in computer tomography you can see it so clearly. Necrotizing enterocolitis. Okay, double bubble sign, the sign of duodenal atresia. On abdominal radiography you can see two air-filled structures in the upper abdomen, and the proximal bubble in the left side filled with air represents the stomach, and the second bubble to the right of the midline represents the proximal duodenum, and this picture is picture of duodenal atresia. Okay, small bowel obstruction. Dilated small bowel more than 3 cm is considered abnormal, and causes of small bowel obstruction include adhesions from previous abdominal surgery, hernias, neoplasms, and other. On X-ray film you can see appearance of small bowel obstruction You can see multiple air fluid levels, especially in central region of abdomen, in erect position of patient. Okay, and the large bowel obstruction, dilatation of the cecum more than 9 cm is abnormal. Dilatation of any other part of the colon more than 6 cm is abnormal. Abdominal X-ray may demonstrate the level of obstruction, and this method can't reliably differentiate mechanical obstruction from pseudo-obstruction. Radiological appearances of large bowel obstruction differ from those of small bowel obstruction. However, with large bowel obstruction there is often coexisting small bowel dilatation proximally. Dilatation of the cecum more than 10 cm and 6 cm for the rest of the colon is considered abnormal. Okay, in these X-ray films you can see also large bowel obstruction. Okay, you can see enlarging of lumen of large bowel more than 6 cm. And in other picture you can see AF fluid levels of large bowel. It's X-ray sign of large bowel obstruction. Okay, and on plain X-ray you can see intra-abdominal calcification, such as stones, such as nodal calcification, such as cystic calcification, solid mass calcification. For example, in this picture you can see gallbladder stone, and on plain X-ray film you can see intra-abdominal foreign bodies with higher density. Let's point out widespread disease of different organs one by one. Esophageal disease. Let's begin by anatomy. You know that the esophagus commences at the level of cricopharyngeus and encephalocardea. It's approximately 25 cm in length, the majority of these being in the thorax with short cervical and intra-abdominal segments. And there are 3 normal esophageal constrictions that should not be confused for pathological constrictions. First of them is a cervical constriction due to cricoid cartilage at the level of cervical 5 or 6 vertebra. Thoracic constriction due to aortic arch at the level of thoracic 4 and 5 vertebra, and abdominal constriction at esophageal hiatus to thoracic 10 and 12 vertebra. Barium X-ray is used during swallowing tests to make certain areas of the body show up more clearly on an X-ray, as you know. And for diagnosis of esophagus disease, this method is so important. Computer tomography for esophageal disease presents detailed images of the esophagus and surrounding tissues. It also helps to identify the spread of cancer to other distant organs, for example, such as liver. In this axial plane, you can see esophagus. Endoscopic ultrasound allows to see the esophagus and surrounding tissues on an ultrasound machine, and this method is used for evaluation of the depth of the esophageal tumor. And magnetic resonance imaging may be useful in detecting esophageal tumors and metastasis. This diagnostic technique offers greater soft tissue contrast than computer tomography. And PET scan is useful for the staging of esophageal cancer. Okay, most common disorders of esophagus are achalasia, gastroesophageal reflux disease, hiatal hernia, Barrett's esophagus, esophageal diverticulum, and esophageal cancer. Achalasia is a failure of organized esophageal peristaltis causing impaired relaxation in the lower esophageal sphincter and resulting in food stasis and often marked dilatation of the esophagus. On X-ray, achalasia appears as a convex opacity overlapping the right mediastinum, air fluid level, small or absent of gastric bubble, and anterior displacement and bowing of the trachea on the lateral view. On fluoroscopy with barium swallow, you can see Bird-Beak sign and esophageal dilatation, as you can see here. Okay, gastroesophageal reflux disease is a spectrum of disease that occurs when gastric acid reflux from the refluxes from the stomach into the lower end of the esophagus across the lower esophageal sphincter. In barium swallow, you can see returning of contrast agent from stomach to esophagus. Okay. And Barrett's esophagus is a potentially serious complication of gastroesophageal reflux disease. In Barrett's esophagus, normal tissue lining the esophagus, the tube that carries food from the mouth to the stomach, changes to tissue that resembles the lining on the intestines. Okay. Esophageal diverticulum are sac or pouch projections arising from the esophagus, and it has three main forms: upper esophageal diverticula, such as Zenker diverticulum, middle esophageal diverticula, such as traction diverticula and pulsion diverticula, and lower esophageal diverticula, such as epiphrenic diverticula. And in all cases, diverticulums are seen as enlarged things which are outlining from esophagus, as you can see here. Large epiphrenic diverticulum you can see in this picture. Okay. Esophageal tumors is divided into parts, of course, benign tumors and malignant tumors. Usually benign tumors, we can see it in long segment of esophagus. They are concentric and smooth tapering and with no mucosal irregularity. But malignant tumors, usually we can see it in short segment of esophagus with irregular narrowing, and they usually associated with mucosal irregularity. In this picture, you can see X-ray film, contrast X-ray film of benign and malignant esophagus tumor. Benign tumors appears in long segment of esophagus with correct borders, but malignant tumors they appear on X-ray film as filling defect with incorrect borders in short segment of esophagus. The ultrasound is used to find out if the tumor has grown into the wall of the esophagus, how deep the tumor has grown, and whether the cancer has spread to the lymph nodes or other nearby structures. And ultrasound can also be used to help get a tissue sample from the lymph nodes. Computer tomography can be used to measure the tumor size. In this picture, you can see advanced adenocarcinoma of the lower esophagus. Okay, I think that you haven't become tired, have you? So we are moving to gastric disease. Okay, and of course about anatomy of stomach. You know that the stomach is a muscular organ that lies between the esophagus and duodenum in the upper abdomen, and it lies on the left side of the abdominal cavity caudal to the diaphragm at the level of thoracic 10 vertebra. The stomach is divided into distinct regions such as cardia, such as fundus, such as body, and antrum. Okay. The outline of the lesser curve of the stomach is smooth, with no filling defects or projections visible, but the greater curve is nearly always irregular due to prominent mucosal folds. In the stomach, the mucus is thrown up into a number of smooth folds, and barium collects in the throat between the folds. The duodenum is attached to the stomach at the narrow pylorus and consists of the duodenal bulb and the descending and ascending portions, although a horizontal segment is often added. Okay. Widespread stomach disease are gastritis, gastric ulcers, benign tumors, and malignant tumors. Okay. Gastritis is an inflammation, irritation, and erosion of the lining of the stomach. It can occur suddenly or gradually. Gastritis is a descriptive term with sometimes conflicting pathological, endoscopic, and radiographic definitions, and usually we can find thick more than 5 mm folds with or without nodularity. Erosions, while less commonly seen, also you sometimes you can see antral narrowing, inflammatory polyps, and the radiological findings are similar to endoscopic findings. In this picture, you can see X-ray, barium X-ray of gastritis. You can see enlargement of mucus folds of stomach. It's normal picture with gastritis also. Okay. On computer tomography also you can see enlarging of mucus field of stomach. Okay. Next pathology is gastric ulcer. Stomach ulcers or gastric ulcer are open sores that develop on the lining of the stomach. Ulcers can also occur in part of the intestine just beyond the stomach. These are known as duodenal ulcers. Both stomach and duodenal ulcers are sometimes referred to as peptic ulcers. Okay, depending on location, you can differentiate benign and malignant ulcers. For example, lesser curvature aspect of body and antrum usually for benign ulcers. And benign ulcers also occur in posterior wall, not usually anterior wall. Almost all lesser curvature gastric ulcers, less than 5 cm in size, are benign. The X-ray signs of gastric ulcers are ulcer niche, with ulcer niche, projects beyond the lumen of the stomach, Hampton's line in a gastric ulcer. It is a thin straight line at neck of ulcer in profile view, which represents the thin rim of undominant gastric mucus, and oedema associated with an ulcer. It forms an ulcer mound. Okay. Tumors, stomach, gastric tumors, benign tumors. The most common benign lesions in the stomach are polyps, and the other common benign stomach tumors are leiomyomas, and they are often asymptomatic and they rise from all layers of stomach wall. For diagnosis of benign tumors, of course, endoscopy, X-ray, and computer tomography are important methods. Okay, in this picture, you can see gastric polyp on X-ray, contrast X-ray examination, leiomyoma on computer tomography. You can see it. Also, polyp. You can see on barium X-ray method this spherical filling defect with correctly borders. Okay. Gastric carcinoma, malignant tumors of stomach, they are has different parts, different types, such as ulcerative, fungating, infiltrative, diffuse infiltrative, and mucinous type. And important signs of malignant tumors are filling defect, of course, and with incorrectly borders. A shallow ulceration with converging folds. The folds are often thickened, regular or nodular in shape, and may have a club-like appearance. The folds may appear the converge. This appearance is due to a fibrous reaction induced by many of these tumors. When the antrum is primarily involved by tumor, it may be severely narrowed or abstracted, as you can see here. And rigidity of the gastric wall and decreased peristalsis indicate submucous spread of the tumor. Of course, on computer tomography is so informative method for diagnosis and staging of gastric cancer. CAT is this method is currently the staging modality of choice because it can help identify the primary tumor, access for the local spread, and the nodal involvement and distant metastasis. Intestines. You know that the intestines are divided into small and large. The small intestine consists of three parts: duodenum, jejunum, and ileum. The large intestine is also divided into the following parts, such as cecum, colon, sigmoid colon, and rectum. The radiographic examination of the small bowel evaluates the mesenteric portion of the organ, which consists of the jejunum and ileum. The following luminal contrast methods can be used to examine the small intestine, such as peroral small bowel series, enteroclysis, various retrograde techniques, and computer tomography and magnetic resonance imaging. Okay, you know that the duodenal cap or bulb should be approximately triangular in shape. It arises just beyond the short pyloric canal and may be difficult to recognize it deformed from chronic ulceration. The duodenum forms a loop around the heart of the pancreas to reach duodenojejunal flexure. Okay. Duodenitis is a term given to inflammation of the duodenum, and it may persist acutely and chronically. On X-ray and computer tomography, they appear as the formation and thickening of mucous folds of duodenum. Okay. Duodenal ulcer also has their diagnostic signs, such as deformity of the duodenal cap may be caused by an ulcer crater, edema, fibrosis, muscular spasm, or a combination of these lesions. Barium in the crater, as you can see here, may appear a niche projection from the general contour of the cap. If it's seen in phase after compression, it appears as an isolated spot, the surrounding edema causing a translucent area. In this picture you can see this translucent area. After the compressing you can see this X-ray picture. If the ulcer is chronic, the folds may converge towards it, giving a stellate appearance. Okay. Enteritis refers to inflammation of the small bowel. When associated with inflammation of the stomach, the term gastroenteritis is used, which is usually caused by infection. Okay. The main radiographic feature of enteritis is small bowel wall thickening. You can see it in computer tomography. Low density submucosal edema can usually be differentiated from higher density mural hemorrhage or infiltration. Okay. Crohn's disease, also known as regional enteritis, is an idiopathic inflammatory bowel disease characterized by widespread discontinuous gastrointestinal tract inflammation. And on computer tomography, usually this Crohn's disease appears as comb sign. Okay, next pathology, appendicitis. Appendicitis is an inflammation of the vermiform appendix. It's a very common condition in general radiology practice and is one of the main reasons for abdominal surgery in young patients. For diagnosis of appendicitis, computer tomography is the most sensitive modality to detect appendicitis. You can see it on ultrasonography in this picture and computer tomography. Okay, and intestine tumors may be benign and malignant, and depending on its improving, they may be endophytic and exophytic. This X-ray picture, contrast examination after barium contrasting of benign tumor of intestines. You can see filling defect, smooth filling defect, and this classic appearance of polyp. Okay, malignant tumors of the small bowel are unusual and account for only 1% to 5% of all gastrointestinal tract malignancies. The types of cancer found in the small intestines, such as adenocarcinoma, sarcoma, and other types. Okay. But large intestines consist of the rectum, sigmoid colon, descending colon, splenic flexure, transverse colon, hepatic flexure, ascending colon, and cecum. And finally, I have talked about diseases, radiology of disease of large intestine. First of all, I will show you contrast examination of large intestine. We name this method barium enema. Barium enema is X-ray exam that can detect changes or abnormalities in the large intestine. The procedure is also called a colon X-ray. An enema is the injection of a liquid into rectum through a small tube, and we use in this method from barium, of course. Normally, an X-ray produces a pure image of soft tissues, as you know, but the barium coating results in a relatively clear silhouette of the colon, as you can see here. During a barium enema exam, air may be pumped into the colon. The air expands the colon and improves the quality of images. This is called an air contrast barium enema. or double contrast barium enema. Okay, in this picture you can see barium enema and double contrast barium enema, air and barium. Okay. In practice, defecography is a dynamic test performed by installing contrast into the rectum and taking the video and still films at rest during strain and during the act of defecation. We name this method defecography. In this method, contrast agent is barium sulfate also. Usually we provide this method for diagnosis of constipation, prolapses, rectocele, and cystocele. Okay. So among of disease of large intestine or bowel anomalies are so important, such as megacolon. Megacolon is an enlargement of the lumen of colon. Dolichocolon is an elongation of the large intestine, and dolichosigma is an extension of the sigmoid part, as you can see here. Hirschsprung disease is a condition that affects the large intestine and causes problems with passing stool. The condition is present at birth as a result of missing nerve cells in the muscles of the baby's colon, and newborns who have Hirschsprung disease usually can't have a bowel movement in the days after birth. In barium enema method, you can see narrowing of rectum in limited part and enlarging above it, as you can see here. Okay, and finally, colorectal cancer, also called colorectal carcinoma, is the most common cancer of the gastrointestinal tract and the second most frequently diagnosed malignancy in adults. CAT scan and MRI are the modalities most frequently used for staging. Okay, depending on it's improving, it's also maybe exophytic and endophytic tumor. Okay, it's barium enema, double contrast barium enema method, and you can see apple core sign. Barium enema showing a constrictive lesion at the level of the sigmoid colon in relation to stenosing annular colon cancer. Appearance of colon cancer, we name it apple core sign. And magnetic resonance tomography, you can see rectal cancer on magnetic resonance imaging. Okay. PET scan for colon cancer is very common for the staging and the grading of cancer. At the end, I have tried to illustrate radiology of gastrointestinal tract, its main aspect and key points. I hope you have found my presentation informative and interesting. Stay healthy, have a good day. See you later.